myself.
Good afternoon, everybody, and thank you, Dr. Park, for inviting me over here to come to Korea and witness that wonderful operation you performed. So I'm from Singapore. My name is Harish. I'm actually in private practice now at Gleneagles Hospital. I previously was in National University Hospital in Singapore. And in Singapore, we have a very small population. It's only about 5 million people over there. And we generally don't see a lot of Pectus excavatum patients. In fact, with a lot of education now, patients are coming forward, but majority of them are just kind of very mild Pectus, so it's not fixed. Where we actually tend to see most of our patients are because we have national service. And so whenever the patients are carrying very heavy load when they are 18 and 19 and marching 30, 40 kilometers, they present with very severe chest pains because of the dip in the sternum, causing a lot of inflammation, costochondritis of the costochondral of the junction over there. So because of that reason, they come in and they get treated by us. So what we did was we know that MIRPE or minimally invasive Pectus excavatum repair is a standard surgical treatment right now. And what the most important outcome, basically, of course, I've learned much more, is to actually put a very standardized kind of an XI method now, bar positioning. But back in my time, we were just using one bar just to pop the chest up. That was our main goal. When we did have some mild defects, but we accepted it then. But one of our main things over there was actually to prevent the bar from displacing, because you want to have the bar in the right position for about 2 to 3 years so it doesn't move around, so the chest can be propped up. So the bar displacement can occur in about 2%. Now what we usually standardize with is the standard clip and lock method kind of a thing, which is the first picture on top, which is all the bars we had at that time. This is before PrimeMed and Dr. Park invented the bridging method. So I don't have this in Singapore. So what we generally have is this, right? So the one with just a single stabilizer, and these are the stabilizer look at. Now, what is the problem actually about what we were finding is that the problem with the stabilizers is they are short and they tend to move at the early stage and they impinge on the intercostals, and they cause a lot of pain to the patients actually. Then if you don't implant it well, you don't curve the bar in correctly, you get skin and wound issues, you can get seroma formation, and then of course tissue damage. Then another method people use is they used to put just sternal wires. The issue with that is that when these are younger kids, right, younger 18 years old, 19 years old for my patient cohort, and the wires can break and they shift around because it's not really holding it very, very tight. So it can fail due to high chest wall forces. And of course, we've always seen this, right, during removal. You always get this osteophyte bone growth over the pectus, some of them, if they're not secured properly. So you can see all this excess bone growth. Where's the pointer? Is this working? Oops, sorry. This one, sorry. Yeah, this excess bone growth over here, over the bone. So you have to do a lot of chiseling and cracking of it. So what we decided is that we said, okay, we'll use zip fix, right? So what is zip fix? So basically, this is a standard way. We used to do it before, and we stopped using the stabilizer, and instead we use this cable and tie thing. It just locks around the rib. So it's actually just like a sternal wire, but this is using a different material, all right? So the aim of the study was to use the zip fix polymer cable tie, and what we did is we felt that it had a stronger fixation, it was easier to apply, it had lower profile implant and lower cost basically than using the stabilizer, all right? So it looks like this. It's made by Diffuse Synthesis. Back then it was J&J, now it's their own company, Diffuse Synthesis. And it was actually designed for this, for sternum closure, all right? So in their data, it basically says it's got a strong cyclical loading, over 1 million cycles per 300 newtons. It was fatigue resistant, it had strong tensioning, it was superior to the wire, that's for sure, and it preserved the bone quite nicely. And the good thing is, after implanting this, I noticed when we want to remove it, we just have to use a normal wire cutter and cut it and pull it out. There's no bone growth over it and stuff. All right, so this is what it looks like. I'll show you the video of this. So you can see here the cable tie, it's a long cable tie, it's stringing around it, and then you clip it together over there and you're done. So we don't do many cases in Singapore. So in my center, we do on average maybe about 7 to 10 a year only. It's not a lot. All right, so compared to all my colleagues over here, their volumes are tremendous. But so we looked at just 20 patients. The mean age was 22 years old, and the mean Heller was 4.5. And what we did was we applied the Zifix pericostally. When we first started, we used 2 on each side, and then some of us decided to just use one Zifix. And eventually we decided that minimum you should do is you should put 2 Zifix to hold it together to really have control. You can put 1 on each side, or you can put 2 on one side. That creates a more stable environment. So this is our cohort of patients. And you can see we had 34 Zifix bands applied. 6 patients had a single Zifix. The other 14 had 2 Zifixes. Some were bilateral, some were unilateral. So unilateral means 2 on one side, some of them, all right? Then we look at the outcomes of this. So this is how it works. So this is before I've learned Dr. Park's crane technique. We just used to just tunnel it through. So again, make the bar, mold the bar, make the cuts on the side, put the camera port in, and then the video should play. So standard tunneling method. Of course, this is before the crane approach. So this is the old video. It's 2017. So we come out to the other side. Now we free up exactly what Dr. Park did today is what we do. So we have this big sword, and then we pass the bar through, we flip it over. And here comes the Zifix part. So camera in. We just make a tunnel, because there's already one cut where the camera is, the bar there. We pass it through, like it's like encircling the rib. You grab it with the Roberts forceps and pull it out around the rib. It's a little bit of a pull over here because the cable is a bit stiff. So then just like a zip fix, like a zip lock, you just zip it up, put it through, and then you lock it in place. And once it's locked, it's very firm. We can just cut off the cable like that. And it's done. So you can see the lock is in place and the bar is very, very stable. So that's what we do. So you can see very clear. So we'll put 2 usually most of the time. And then you can see here there's no stabilizer at the side. The bars are in place over here. So basically, at the end of the day, that was our conclusion. It's safe. So until I get the bridge or the prime mat Pectus bar, I don't use the stabilizers anymore. I just use a Zifix. And so now even if we put two bars, we just use a Zifix around it. So with that, thank you very much. Yes. Are there any questions for me? Yes, sir.
Which Pectus bar do you use?
I think this brand is from Biomed, I think.
As I know, the Biomed bar is very little.
Yeah, very small.
So how would you advance?
Oh, no. So this is not Biomed then. I take it back. This is the exact bar we use. It doesn't have a hole. We encircle the bar, the rib is here, the bar is here, we encircle around the bar and the rib. Not through the hole, no.
So it's going to be in the middle of the bar or somewhere.
Yeah, it's same thing like when you do, yeah, you can see here the bar, and then this around, so the bar is on the rib here, and this is going around the rib.
So what's your bar dislocation rate so far?
So far, thank God, we didn't have any bar dislocation, but we had something that snapped. So what we end up going in for one patient, we have to put another zip fix. So that's why I said from now on we use 2. So most of the time you can do 2 around a single side, or do 1 on each side, or if you really want to do, you do 2 on each side. But so far the strength is quite strong for it.
So how long?
I see the patients once a year. 3 years, we take out the bar.
Yeah, I know that, but the follow-up period.
Oh, for those patients, up to 17, I think was 3.
It's almost 5
Yeah,
5 years.
more than 5 years. Yeah. So these.
You may remove some of the bars from.
Yeah. So basically, you can see 16 bars were removed at the time of publication.
Okay, great.
Yeah.
Actually, I did a lot of all kinds of the fixation methods in the past.
Yeah.
But all those were not perfect.
Yes. I agree. I mean, I see your bridge technique. I think that to me seems to be at this current moment in time,
And I
probably
have
the
to
best
say,
method. Yeah.
I have 0 bar dislocation
Yeah.
out of 2,000 patients with the bridge fixation.
Yeah. This one, there was one patient, I remember the patient felt a snap, but the bar didn't move.
I did a few
So,
cases with this, but
yeah, okay.
very few.
All right.
Thank you.
Thank you.
Are there any questions from online audience? If there are no further questions, we'll move to the next two topics. Next topic is next topic is multiple Pectus Excavatum repair in pediatric population by Dr. Cheng-Hao Chen and Chi Cheng.
Okay. Hello, everyone. And my name is Cheng Hao, and I'm from Beijing Children's Hospital. And thanks to Professor Park for the invitation. And it's my great honor to represent our team here to share our experience on the use of multiple bar technique for the treating of pectus in children. And we know that Pectus excavatum is the most common congenital chest wall deformity. And in 1998, Dr. Nuss reported the minimally invasive surgery for Pectus in journal Pediatric Surgery. So compared to the ravage open surgery, the Nuss procedure offers significant advantages, including minimal trauma, rapid recovery, and superior cosmetic outcomes. So, and then Professor Park, the pioneer in the field of Pectus treatment and a very famous international expert, he introduced numerous magic and innovative theories and techniques, including classification system for Pectus, and a treatment approach for asymmetric cases, and others like hinge plate, claw, fixator, and also the NBA techniques and more. So his contribution have profoundly advanced minimally invasive pectus surgery. So we in China, our team began to perform NAS procedure in 2000. So far, we have completed over 9,000 cases. So our data indicates that single bar techniques predominate at about 84%, while the double bar and the triple bar approach comprise 16%. And multi-bar techniques are usually applied in older patients over 12 years old. It's about 90%, with those under 12 years old accounting for 10%. So throughout our long-term clinical practice, we consistently adhere to two core principles And one is minimizing surgical trauma. And the second is enhancing surgical safety. So at the same time, we achieve satisfactory cosmetic outcomes through varying numbers of Pectus bars, placement, locations, and fixation techniques. Among these, the number and the position of Pectus bars is a focus of today's our topic. So the main surgical techniques of our team are thoracoscopy and chest wall elevation. The real-time thoracoscopic visualization can minimize the severe surgical complications. And for younger children with elastic, soft chest walls, the anatomical structures between the sternum and the pericardium can be adequately exposed through the lifting action by the introducer. For the older children with rigid chest wall, and we elevate the chest wall using wires or suspension devices to achieve the surgical visibility and reduce the surgical complications. And other techniques applied in specific situations primarily include the first is additional incision, mainly used for children with congenital heart disease previously, or the same-stage surgery. And we do not use this technique in routine Pectus excavatum surgery. And the second is suspension. Anterior suspension technique are applied in cases of severe retrosternal adhesions following congenital heart surgery. And the third one is extrapleural techniques. These techniques are mainly used in patients with thoracic surgery history or recurrent Pectus excavatum after the initial repair. The number and placement of bars have also evolved over time, and the early techniques relied solely on single bar, and then double bar techniques in 2004 in our team. And then we performed the crossbar and the sandwich techniques and others. In the fixation technique, we from the early double stabilizer and to single stabilizer, and then to wire fixation and bridge and absorbable or non-absorbable sutures. Typically for children under 10 years old, we usually use a single bar technique combined with oblique or unbalanced placement to address asymmetric Pectus excavatum in younger children. With accumulated surgical experience, we observed that most older Pectus excavatum patients exhibited extensive chest wall depression, which cannot be adequately corrected by single bar technique. So as seen in the two children, a significant depression is present both above and below the nipple line. Single bar techniques fail to sufficiently correct in such cases. In the two patients, we can see the significant depression is present both above and below the nipple line. So consequently, we adopted the parallel double bar technique. The two bar are placed parallel and supporting the upper and the middle regions, can secure with the stabilizer. And these patients Yes. So this is a similar case, and we employ the parallel double bar technique combined with bridge technique, connecting the two bars at the lateral chest wall to enhance the overall stability. This is another case. As shown in the picture, how should we address this patient with middle and the lower chest depression? Yes, so in this case, we use the double bar and crossbar technique, which effectively corrects the lowest point of the depression and the lower chest wall depression. And additionally, the cross technique offers superior stability compared to parallel double bars, as the bars make the surface contact with each other. For patients with extensive pectus excavatum, like the one in this slice, where the upper, middle, and the lower regions are all depressed. So we employ 3 bars to support the upper, middle, and the lower region. So this achieves complete correction of the chest wall deformity. And for complex deformities such as pectus excavatum combined with pectus carinatum, where the upper chest protrudes while the lower chest is depression, or with one side of the interior chest wall convex and the other concave. So in these complex deformities, like this case, we employ a pressing upward and supporting downward strategy to achieve excellent results. And in this case, the same like pressing up and pushing down approach is applied. And this child also has some left lower concavity. So we addressed with oblique bar placement. For this recurrent case, the chest wall is typically rigid. So we employed a sandwich technique at the same level of the chest to correct the deformity. And in this case, this is a very severe case. And we first corrected the pectus excavatum with 2 bars, then used a 3rd bar to correct the pectus carinatum to achieve favorable outcomes. Okay, so reviewing our past experience, multi-bar techniques can achieve favorable correction in older patients with extensive pectus excavatum depression or those with concomitant pectus carinatum. So our single center experience shows virtually no recurrence in older patients treated with multi-bar techniques. Okay, that's all. Thank you.
If you have a question online, please leave it in the chat. Are there any questions?
Dr. Chen, wonderful. Thank you for all those wonderful words and great work on your team. I actually want to know a little bit more about the carinatum. I understand there's another carinatum talk also. But I want to know that when one of those pictures of the arcuated patients, how did you anchor the carinatum bar, the external bar down? You just push it down and tie it to the rib?
I'm sorry.
For your patient that has a carinatum and excavator.
Yes, okay.
How did you manage to push the carinatum down? Because I didn't see a sandwich technique. I saw 2 separate bars.
Yes.
And how did you push it down and anchor it?
The pushing down technique, like the pectus carinatum, just under the skin.
But how do you keep it there?
Yes, and then use the stainless steel wire to fix the rib.
And it won't slip up again?
I'm sorry.
It won't move up again?
No.
It
no.
won't slip?
Yeah.
Okay.
Okay.
Great series of 9,000 Pectus repairs, 26 cases a day.
Yeah.
How long is your day?
24 hours.
240 hours. I have a question that how much your single bar cases, how much the dislocation rate or something?
张老师他问咱们单板的移位率有多少？ Yes, and these years we maybe 2-bar techniques will be more than the single bar. So
Why you
yeah.
want to the bars from the single bar?
One reason is the patient's age. I mean, we do not maybe the patient's age will be more than 10 years old to receive the surgery, and the younger patients we may use vacuum bell to try to correct.
With the age factor, the older patient get the multiple bars, and
Yeah.
the younger ones
Yeah.
still using a single bar.
It's still a single bar, yeah. In younger
Actually,
patients.
We all started with the single bar 25 years ago, but over time it's more and more discouraging and disappointing. More dislocations and then the less coverage of the chest wall, so you have a lot of insufficiency and failure like dislocations. So I completely stopped using the single bar because I know multiple bars are better than better than the single bar. So there's no reason to continue single bar. And then at the beginning we are very concerned about how many bars we can put into the patient chest. But over time, with the accumulation of experience and then a lot of data supporting the multiple bar exclusively safe for patients. So more and more, we don't have any reason to do the single bar right now. Maybe you can save one bar, but you cannot save the patient's future. So that's one reason. And still, we have a very small percentage of the bar dislocations in general, but I don't want to see any kind of bar dislocations or mishaps with the bar issues. So once I move to the multiple bars with the bridge fixations, I have zero bar dislocation rate over thousands of patients. So I think I don't have any reason to do the single bar anymore. What do you think about that?
Yes, we agree the technique of multiple for the older children, and in my opinion, if the patient is in a younger age, maybe 2-bar is a little bit more for the children because the space is not enough to put 2 bars. And also in our data, we just calculated the database, and maybe we have several patients in younger age. They have the bar displacement. But we to make the status, I don't know how to say it, to compare the two groups, and the P is less than 0.5. So in our opinion, that exactly the number in the younger patients, they have displacement, yes, but the P is still very small. So nowadays we have vacuum bell, so we use vacuum bell in the younger patients, and then maybe 2 bars in the older than 10 or 12 years old. Yeah. Okay, thank you.
By the way, the operating room is ready for the next case. So we will need to move on. 수술관 준비하겠다고
발표까지 하시고 넘기시고
다 하시면 없을 것 같은데.
이제 첫 번째 세션에서 한 번 남으셨거든요.
아, 그런가?
예, 하고 옮기시면 될 것 같아요. after last presentation, we have to move the operation rooms. Operation room is ready for surgery. 뭐야? After your presentation, we have to move it.
Because associated, that's the kind of one slide. Yeah.
Previous next.
Yeah. So if I put the power force to that is my you must always put a bar inside. Yeah, I think so. And in current infant cases, have you put four multiple bars? Yeah, 3 bars. 3 bars. Externally 3 or one external, 2 internal. 2 internal.
Next two, we will discuss Pectus carinatum repair in pediatric population, presented by Dr. G.A.U.
Good afternoon, everyone. My name is Yu Xie. I'm the colleague with Dr. Zeng and Dr. Chen. Come from Beijing Children's. Come from Beijing Children's Hospital. Okay. So, Pectus carinatum is the second most common congenital chest wall deformity in children. Okay. Following the PC can be classified based on its morphological features. The two most common types are the sternal body type, where the main body of the sternum protrudes, and the manubrate type, affecting mostly the upper sternum. And there is a less common type is clavic manubrate type. It involves the clavix and the upper part of the sternum. A rare and complex variant is CS syndrome. It is characterized by premature closure of the sternum, ossification centers, leading to a short, wide, and sharply argued sternum. It is also associated with congenital heart defects, while morphological classification is useful for describing the deformity. It does not directly guide surgical planning. To address this, we developed the PCH classification system. It is a surgery-oriented system designed to guide decision-making. This system classifies PC into 4 main types based on the location and the morphology of the protrusion, and also its associated depressions. So we can say type A is protrusion of the sternal body based on the contour of the protrusion. Type A is further divided divided into A1 gentle slope and A2 sharp ridge. We can see type B is protrusion of the manubrium, the upper part of the sternum. So B1 is a gentle slope, while B2 is a sharp ridge. B2 is often seen in patients with CS syndrome. And the type C is asymmetric deformities. This includes C1 gentle slope, C2 sharp ridge, and also C3 sharp ridge with an associated depression. Type D is severe pectus carinatum combined with prominent Harrison's grooves. And based on our classification, we select the most appropriate approach for each type of deformity. For the type A1 and C1, which present as simple, gentle slope protrusions, we use the minimal invasive sternal depression technique, which usually named Epperson technique. For type A2, B1, C2, and C3, which the protrusions with associated depressions, we use sandwich technique. The traditional aberration technique has limitations in these cases. So because compressing the sternal protrusion may lead to worse underlying depression. The sandwich technique, which was first named by Professor Park in 2018, overcomes this limitation by using a two-bars approach. The sandwich approach allows the correction of both deformities and results in a much more balanced and natural chest contour. For type B2, which is a manubrium protrusion with depression and is also seen in CS syndrome because of the rigidity and the complexity of the deformity, we usually perform a sternal osteotomy combined with a NAS procedure. And in the type D patients, which is severe protrusion with a deep Harrison's groove, in these cases, we use the rib bypass 10 technique, and I will show you in the later. Overall, this classification-guided strategy allowed us to select the most appropriate surgical technique for each specific deformity. A critical part of our preoperative planning is manual sternal compression test. You can see we often do this in the clinical outroom. The test helps us to assess the elasticity of the chest wall, and we can identify which kind of identify either concurrent depressions that may become worse with the compression. Intraoperatively, we also use a pressure gauge to precisely measure the force required to correct the deformity. This measurement is important for determining the most appropriate fixation method for the corrective bar, whether it be wires or stabilized plates. This helps ensure stable flexation and prevents bar displacement. For the simple cases, as type A1 and C1, we perform the aberration syndrome. A single molded bar is placed submuscularly over the sternum by a bilateral incision. The bar is then secured to the ribs, typically to the number 5th or 6th ribs, using either steel wires or stabilizer plates. The bar is removed usually after 1 or 2 years. As I mentioned before, the choice of fixation is determined by the intraoperative pressure measurement. In cases of lower pressure, a single double wire fixation is usually performed. In case with moderate pressure, we use a combination of wire on one side and a stabilizer plate on the other side, particularly in asymmetric cases. And in the case with higher pressure, usually upper 10 kilogram, we use bilateral stabilizer plates to ensure maximum stability and prevent bar rotation. Okay, The sandwich technique is our primary method for complex pectus carinatum cases with associated depressions. We use two variations of sandwich technique depending on the anatomy of the deformity. Variation 1, different planes. You can see the extrathoracic and intrathoracic bars are placed on different level. This is our standard approach for most complex cases. Variation 2, pure, we call it pure sandwich. In this procedure, both bars are placed on the same level, directly opposing each other to sandwich the chest wall. This technique is reserved for selected cases where maximal correction of both the protrusion and the depression is required in the same anatomical location. I can see this patient. This patient presents with type A1 deformity, who characterized by a sharp ridge protrusion of the sternal body. We perform the sandwich procedure. This is the next case is a type B1 deformity characterized by protrusion of the manubrium with a gentle slope. Again, we use the sandwich procedure. And this is a type C2 cases whose deformity with asymmetric sharp range protrusion. Asymmetric cases can be particularly challenged to correct using the sandwich technique. And this is a type C3 case, which is a recurrent Pectus excavatum patient. He presents with asymmetric protrusion with an associated depression. We use the pure sandwich technique, placing both bars on the same level. And this case is an 8-year-old girl with a history of VSD repair and CS syndrome. She presented with a complex B2 type deformity. For patients with such complexity and rigid chest wall, we perform a sternal osteotomy combined with a NAS procedure. And this patient is a type D case who characterized by severe pectus carinatum with a significant horizon groove depression. Our specialized rib bypass technique is used here. The bar is carefully passed beneath the depression rib, allowing them to be evaluated while correcting the sternal protrusion at the same time. So the bar gets by the chest tube. So in conclusion, minimally invasive surgery has become the preferred approach for correcting PC due to its reduced surgical trauma, shorter hospital stay, and excellent cosmetic outcome. And second, the sandwich technique presents an important advancement. So thank you. That's all. Okay. Thank you. And welcome to Beijing, China. Okay.
Are there any questions here? Okay.
I didn't understand exactly I don't think it's a Harrison's group, but something we have bilateral depressions and the central protrusion. What was your surgical technique for that?
Sorry, can you say again?
Like
The horizon group, what?
yeah, that kind of deformity. How did you fix that? The repair technique.
Repaired. Only with horizon group, or you mean the
you saw
PC with a horizon group?
Uh-huh.
You mean the type D technical? This one?
Yes.
Oh.
Yeah. How did you do it?
Like this picture, we put the bar.
We can only see the one bar.
One bar, yes,
Yeah.
one bar. Because horizon group always under the how to say, under the the lowest point of.
You mean the like this way, the come out to
Yes.
externally and then internally.
Yes.
Oh, yeah.
In
Like a
in
complex
thoracic
pathway.
and out and in and out.
Oh, yeah. Actually, I have just a bit few cases, but I did what I did was crossbar sandwich, like crossbar to cover the postlateral inferior here, and then the sandwich externally. So this part must be supported from below, and then we can push down the internal X and the external I, like that way.
In the same level.
My bars are always follow the target, so when the depression is there, the internal bar goes there. And for the cardiac patients, once we push down, we can find where can be the depressed while we are pushing the protrusion down. So in that point, we can support the internal bars, and then the external bar can press down the cannulated part.
Yes, but sometimes the horizontal groove is not in the is very lateral.
Yeah, so that's why we can put the crossbars inside.
Okay, we can discuss later. Good.
Any questions? Okay. Now we will begin the next session. The first presentation is multi-bar approach with crossbar and the XI in Pectus excavatum repair by Professor Kwon-Yung Kim.
관용현.
강윤현.
현. Yeah. Good afternoon, everyone. This morning, we had an excellent opportunity to watch the live surgery and see the techniques in action. So in this session, I'd like to step back a little and talk about the concept behind the multiple bar approach, particularly the use of crossbar and XI configuration in Pectus excavatum repair. I'm Kwon-Yung from St. Vincent Hospital, the Catholic University of Korea. About 10 years ago, I had the privilege of training under Dr. Park at St. Mary's Hospital. That experience is the reason why I have the opportunity to stand here today. Let me begin with a simple question. Why do we use multiple bars in Pectus repair? The answer lies in the mechanical advantages created by multiple bars. First, force augmentation. When two or more bars work together, the lifting force is amplified. Second, load sharing, which improves the overall stability of the construct and reduces the risk of bar displacement. Third, wide coverage, allowing us to support a broader area of the anterior chest wall. And finally, targeted lifting, particularly in the crossbar configuration where two bars converge on a single target. With these advantages, we can achieve entire chest wall remodeling. That means we are not just lifting the sternum, we are remodeling the entire chest wall. Once we decided to use multiple bars, the next question is how to configure them. Different deformities require different bar configurations. On the left, the parallel bar configuration mainly provides wider central coverage. It is useful when the depression extends vertically along the sternum and we need to support a broad vertical area. In the middle is the crossbar configuration. When the two bars crosses at the deepest point, the lifting force is amplified and the lateral chest wall can also be covered more effectively. Finally, the XI configuration combines the advantages of both techniques. By adding an upper horizontal bar to the crossbars, we can achieve broader coverage while maintaining strong targeting lifting. Based on our experience, we summarized the main indication for the crossbar technique. The original indication was focal and rigid depression, especially at the G-fisternal area. In this situation, crossing two bars allows the lifting force to converge on a single target. However, as our experience increased, we realized that application could be expanded when bilateral costal depression is anticipated after parallel bar placement, because the tangential support of the crossbar can prevent hinge compression. In addition, the crossbar is effective for lateral chest wall depression located below the sternal tip. Another important indication is reoperative cases after a failed nurse procedure, where precise targeting and stronger support are needed. Finally, when an additional upper bar is added in XI configuration, the techniques enables remodeling of the entire chest wall. So in practice, the crossbar technique can be applied to a wide range of complex deformities. Now, the next question is how we choose the appropriate bar configuration in real clinical practice. I will show you 9 real cases. This is a 14-year-old female with an asymmetric deep cave-like deformity. The depression extends all the way from the nipple level to the xiphoid with a right-sided shift. To cover the right lower chest wall, I use XI configuration. The second case is 18-year-old male with a symmetric focal deformity. There is some depression at the nipple level.
Dis-13-Y-EAR 올드메일 위드한 어시메트릭 딥 디포미티.
So the broad area is covered by the XI bar configuration. In this case, the patient is a 13-year-old boy with a symmetric focal deformity. The nipple level looks normal. But the depression runs transversely at the xiphoid level. So I decided to use only a crossbar configuration. So the nipple level was almost normal, so no more upper bar was needed. The patient is a 20-year-old female with symmetric Grand Canyon type deformity. The depression extends all the way from the nipple line to below the xiphoid. So the choice was a parallel bar approach. The depression was all the way from the nipple level to the xiphoid. This is a 36-year-old male with a symmetric, also a Grand Canyon type deformity. The depression is less severe than in the previous case, but there is long, deep depression extending from the nipple level to the xiphoid. As you might expect, a parallel bar configuration was selected. Only parallel bar can achieve adequate lifting of the chest wall. This is a 13-year-old male with a asymmetric, deep deformity. The depression is mainly on the right side, involving the nipple level and the xiphoid. A parallel bar was tried, and the bars were placed in a skewed orientation to cover the right side of the chest wall. So sometimes a parallel bar in a skewed orientation often works. This is a 16-year-old male with an asymmetric deep deformity. The depression involves the nipple level and the right lower chest wall. An XI bar configuration was initially considered, but we ultimately used a parallel bar configuration in a skewed orientation. Here we have a 16-year-old male with an asymmetric broad type deformity. So many broad depression is here. The depression is mild at the nipple level and more prominent at the xiphoid level with a right-sided shift. You can see a broad flattening. So in this situation, an XI bar configuration was used to cover most of the chest wall area. Upper bar and the crossbar, adequately lifting the chest bar. And the last case, this is a 13-year-old girl with an asymmetric broad type deformity. The depression is mild at the nipple level and more prominent at the xiphoid level with the right-sided shifting. The choice was almost a no-brainer, so I used an XI configuration. So I'm going to show you my operating cases. This is a case of symmetric broad type deformity classified as 1AT in Park's classification. The letter T indicates a transverse depression running in the xiphoid level. A 15-year-old male, the chest wall shows a broad depression running transversely, and the nipple level is also depressed, and it extends down to the xiphoid area. First, we check the shape of the pectus bar. Yeah. Sometimes the bar is not properly shaped, especially when it has been bent by someone who is not familiar with the bending technique. So I rebend the bar myself and carefully reshape it to match the contour of the patient chest wall. Basically, when shaping the bar, we give more curvature at the area corresponding to the chest wall depression to achieve adequate lifting. Next, mid-axillary line is marked to determine the incision sites. We then measure the transverse and the diagonal dimension of the chest wall to guide the bar shaping. The horizontal was 14-inch and the 15-inch was selected. At this point, a betadine solution is poured over the chest wall to visualize the contour of the depression more clearly. You can see the depression extends up to the nipple level. The hinge points and the depression area are then marked on the skin. Next, we perform wire-assisted sternal elevation to lift the sternum and create a safer working space. A thoracoscope is inserted to inspect the thoracic cavity, and under the thoracoscopic visualization, a full mediastinal dissection is performed to create enough space for bar placement. You can see the puncture point on the contralateral side, and the guiding tube is inserted to facilitate safer bar passage. Now the first bar is flipped and placed, and the puncture for the second bar in the crossbar configuration, and the guide wire for the second bar. You might see this in the live surgery in the morning. Yeah. And we chose to insert the upper horizontal bar to make an XI configuration. The uppermost horizontal bar is inserted to complete the XI configuration. All three bars are then connected with one bridge plate and securely fixed with screws. I am fixing the screws on the right side, and then you will see I'll move to the contralateral side because there was no experienced assistant. I have to work on both sides of the patient myself and keep moving back and forth. And after placing XI configuration bar, we can fix the prominent costal flare by placing a flare buster thread subcutaneously. HAP drain is inserted to the thoracic cavity, and the on-cue pain buster is placed to relieve the pain. So finally, we can see the post-operative chest wall contour demonstrating successful entire chest wall remodeling. Yeah, this video is exactly same the situation you saw in the OR in the morning. Yeah. So to conclude, I have to say that successful pectus repair depends not on the number of the bars, but on choosing the right configuration for each deformity. Thank you for your attention.
Is there any questions, online or offline? Okay, thank you.
아침에 그걸 못 해가지고 같이.
요거 위에 레이저 포인트 거기 요거 네. 위아래 그 슬라이드 주셔야죠. 네, 감사합니다. 제목이 다른데.
Hello, everyone. Pleasure to be here, and we're gonna share the no-brainer XI bridge technique, which is shown, demonstrated in the morning and then right before. This is a data-driven, not from the imagination. It's a data-driven formula for a multiple Pectus Excavatum repair. It's trying to transform complexity into simplicity. We have a number of options to select bar configuration, like a single bar and a parallel bar and a crossbar, or XI bars. Probably there are pros and cons on every technique here. But the traditionally minimally invasive repair didn't have any standard formula, and mostly operator dependent, and the consequences heterogeneous outcomes and the bar displacement risk and residual deformity and the limited multi-bar adoption. So this is the decision tree for the traditional technique. When we see the patients, just before the Dr. Hyun described this to us, how he can decide which technique and which bar configuration, how many bars. So number of bars, 1 bar, 2 bars, or 3 bars, cross, parallel, or XI, which intercostal spaces, how can I fix those? And this is a kind of surgeon dependent. Everybody thinks differently. So this kind of approach can result in a good result outcome, or sometimes bad, or sometimes a total failure. So it depends. Like you see here, traditional tree of decision making is so complex. Everybody has different decision to make. But MBA XI bridge is only one pathway, and then every time the same approach, same results, and then the same tactics, whatever. So by this formula, we have no complexity. We have no uncertainty. No-brainer approach, the philosophy of no-brainer approach is formula replaces the judgment, and the data-driven, not experience-driven, and standardized for any patient, and immediate learning curve. So we don't need to learn very much. We don't need to judge at all. So the multiple bar repair make the chest wall disease from transforming the simple little bit more on the provides most reliable, little bit more on the provides most reliable and the most wider, most convincible results to us. So the answer is very, very obvious. What we can choose. You want to choose A, B, or C? Again, this is the John theory. If you want to cover only John 1, you can choose single bar. And John to cover only John 1, you can choose single bar. And John 1 and 2, parallel bars. John 1 and 3, you can choose. This is a model for the 654 XI bridge technique. This came from the data analysis. I analyzed the 133 patients who had recently XI bar technique. So I counted the right side lower, it's a 6th intercostal, and right upper was a 4th intercostal mostly. If you compare here, is predominantly this one, and the lower left side also the L6 and L4. And in total, we have R654 has dominantly on the right side, and the L654 is dominantly on the left side. So why we choose others? So if you set up this kind of formula, must be the easiest method for multiple bar repair, and this is kind of a universal formula for everybody. So 654 intercostal at the right anterior axillary line, and more conveniently below nipple and above nipple, as we see in the morning and in the afternoon. So yeah, if we draw the nipple line here and the anterior axillary lines, bars can be configured like this way. No exception. This is a universal rule. Again, but the one thing we need to keep in mind is when we start at the intercostal 6 here, we have to pass 2 targets here. The deepest point of the chest wall depression, and then the tip of the sternum. You cannot put the bar below the sternum or somewhere. So finally, 6, 2 targets, and 5, 2 targets, and 6, and finally at the first intercostal space. In patients, the same applies here, 6 targets and 5 targets to 6. By this way, we can cover the entire anterior chest wall, no other way. So again, the diagrammatic illustration shows the XI and the nipple line stands here. It's so simple, and nobody can miss this. Internal view shows the crossbar here and the upper bar here in the mediastinum. And with this kind of approach, we can achieve every time the universal, like a 90%. It might not be perfect, but at least we can achieve 90% repair outcome. So we need to crane up high. One must is the crane. With the crane, you can do this. Once you crane up the chest wall, the asymmetry disappears, and then the focal lesions disappear. So you can just put the bar. You may need just a little bit of bar configuration there, but still, it's very easy and universally acceptable repair. So this is a conceptual metamorphosis. Why we think every time one single thing. It's been over 25 years. So why do I have to do the same technique as the 25 years ago? So formula over complexity, safety confirmed, whole chest remodeling, and paradigm shift. This is the subject on the no-brainer technique. May I take questions and then move on to the next one? Because the next one must be the Pectus Kernatum. Yeah.
Is there any question?
So Dr. Hyun might be very happy with no more he need to think about anything, 2 bars, 3 bars, where to put. Just draw the nipple line and then put the bar in there. So nothing more than that. Myself, it's a rule to put the bar. As you saw, we saw 2 cases, exactly the same approach. No hesitation or no decision making or no judgment yet. 안 되는데요.
현관용 선생님께서 보이시는 팔로 CT 보면 브리팅 플레이트하고 원이 소락사하고 조금 뜨는 게 계속 보이더라고요.
네.
근데 이제 박경규 선생님 보여주셨던 그 팔로업 CT에서는 그런 것들이 이 디스턴스가 별로 뜨는 게 없어가지고 혹시 그게 어떤 경험상의 차이인 건지 뭐 저한테 좀 답변해 주시면 현관용 선생님한테도 좀 도움이 될 것 같긴 한데요.
그걸 답변을 하면 절로 도움이 된다는 게 이해가 잘 안 되네. His question was, Dr. Hyun's cases, we have some gap between the bone in thorax and then the pectus bars there. There may be 2 factors. Actually, the bars are separated from the chest wall, or the patient has a more soft tissue or muscular tissue apart from the bony thorax. Actually, I saw sometimes something bigger gaps between the structures, but do you see any sticking out the bars with the other patients?
Not that much, but sometimes the bars.
Yeah, you are not very strict to the bars to contact the chest wall.
I try to bars are containing the chest wall, but sometimes I cannot.
Yeah, well, actually, you may saw the maneuver we did. Dr. Lim and I did like pushing the bar because when the end of the bar is not very fit to the chest wall, in those instances we bend more with the. We can throw the bar out and then reshape it, but if it's a gap is very large, but in most cases we can adjust just a little bit. I just call this Sharapova technique. We have a lot of grunting with those techniques, but we can do it that way. Yeah.
I don't think that because the XI and all the multiple bars are connected each other, so there's some cosmetic problems of like a protrusion, but when the patient ages, the chest cavity is becoming bigger. So in that case, there's like some gapping between the bars and chest wall. I think it doesn't cause any problem. That's my opinion.
Exactly the purpose of this workshop is that one, the no-brainer approach, because it's a kind of I developed that just a couple of years ago, so it's pretty new, and then most people are struggling to find out how can I do better, like Dr. Hyun. I'm sorry, but we have a lot of thoughts crossing mind, and it's a little bit hard to decide which way is the best way. So I try to help you with the formula that you can follow anytime, and then you can get the universal outcome. As you see today, it was pretty straightforward because we already lifted the chest wall very high. So yes.
Flat Pectus patient.
Flat Pectus.
Yes.
Yeah.
You use the MBA technical?
As I already told you, I have no judgment. My
So
brain
you-
is empty,
The,
so I do always the same thing.
okay.
That's all I-
It's work. It's good.
I don't know anything other than that.
Okay.
Maybe you are pretty suspicious. Can it be applied every time successfully? But it does. So yeah, trust me. We saw already two cases. The first case was a little bit asymmetric, kind of Grand Canyon type. One region, when we lift the chest wall with the crane, and it's already fixed the chest wall, and then we just put the bar in there, the support. We don't push up the chest wall with the Pectus bars. Elevating the chest wall is the crane, not the Pectus bar. So it's already up high, and then we just put the bar in a most stable configuration, and then the best supporting configuration of the chest wall. So, as I told you, only XI bar technique can cover zone 1, 2, 3 altogether. No other techniques. So I know that because other crossbar or parallel bars are some shortage. I know that they are not always perfect. So how I select imperfect technique, and I know the perfect one. So just natural way. And again, we had a concern that how many bars we can put in, and is it too much, or in the beginning we didn't have any experience or any data, so we were worrisome about those. But already I have over 1,000 cases of the XI here, so I have no worry about that. So I provide data to support those notions. Any other things? Just empty your brain and do the XI. That's the best way. No other problems. The patient can go home tomorrow. So if the pain is okay, that's what we do in Cleveland Clinic. Cryo, intercostal block, and then no brain or XI, and the patient can go home tomorrow very happy face. So no more struggle. There's a Pectus family with the Excavatum, Carinatum, and the Arcuatum. This is Excavatum. This is Carinatum. This is Arcuatum. And then we have another type of, recently I give the name for this in the Pectus concavo convexus, because horizontally we have two components of the chest wall deformity. Many people say like Abramson technique or something, pushing from above. That's a kind of a single vector approach. Single vector approach is like a NUS procedure and or suction cup, or for the Pectus carinatum, Abramson technique or bracing, just pushing or lifting only one force. But always we need a bidirectional vector approach. This is a neo-Pectus concept. So make the chest wall flat, you need always two different types of vectors. For the Excavatum, we use a crane and the flare buster. It's a different, the opposite direction of the vector. And the carinatum, compressor, and the sandwich technique, something like that. In Pectus carinatum, actually Harish raised the question that when we push down only with single vector approach, what happens here? Chest wall goes down altogether. So this kind of things happening. So we need a counter force to make it straight. This way, we need always two vectors together like this way. For the Excavatum, this also has a, once we lift the depression, what happens is this is what we call the lower costal flare. So we need to push down with the flare buster. So every time, regardless of Excavatum, carinatum, whatever, we need dual action forces. Those are the sandwich technique concept. We have three different types of variation sandwich in the flare buster or the magic strings. Basically, dual force, opposite direction. For the symmetric carinatum, just so we can sandwich them very easily. This is an example of the sandwich technique, asymmetric Pectus carinatum. Two internal bars and one external bar. Two internal bars in, and then the one external oblique way, and with the aid of a compressor, we can align all three bars together and linked to the single bridge plate. For the asymmetric keratoderm, the same thing goes here. This is a case with the extreme keratoderm, but we could fix with the this kind of sandwich technique. Another case, this is the internal X and the external I, two eyes here. First, the 4-bar sandwich for me. It was done in Switzerland with the another doctor there. What is a Pectus concave or convexus? This is a kind of new term and a mixture of excavatum and keratoderm, like this way. So we need definitely we need dual vectors here. The diagram shows the keratoderm and the excavatum together. So this kind of deformity only can be fixed by the sandwich technique, no other techniques. This is the example. It's done probably early 2000, and then it was very difficult, but the result was satisfactory. This is a keratoderm repairs. This is a crossbar sandwich technique and the parallel bar sandwich. This is an example that first of all, target setting here, mark the targets. This is the carinated part, target number 1, and this is the excavatum, target number 2, and the flares here. So plan is the cross sandwich. The reason for the cross is we have a number of targets to be covered at the same time. Now you see the this part is elevated, and then you see that this part is elevated. Now the main target must be fixed with the external bar this way. With the aid of a compressor, in this case, mostly we use the easy compressor for the keratoderm repair. Otherwise, the consistency is not guaranteed. So this is the end result. As you see, we can achieve very, very symmetric, flat chest wall. No obvious residual. This is another case. You can't do this complex deformity with a no-brainer technique. You have to think about something. Lifting the depression. And finally, to compress the carinated part. because this is kind of a ridge, like a crest here, so we needed 2 external bars. And this is the hook puller. This is a compressor. We use the hook puller, not shown here, but anyway, 4-bar procedure. Looks pretty symmetric. Another subject is the Pectus arcuatum. Mostly it's treated by the open repair, like a cartilage resection and the osteotomy or something like that. But I tried hybrid sandwich technique with this. Minimally invasive repair of Pectus arcuatum. This is not an extreme case, but try to show you the just the basic idea of treatment. Internal bar lifts the excavatum, and then I tried to make a sternal osteotomy, a sort of a closed osteotomy. The dissection was done under the protruded part of the manubriosternal junction there. And the guide is passed. And then through the guide, jiggly saw was passed. And closed sternal osteotomy was performed. And then this kid has a very malleable bony structure, so I use the Ethibond instead of the Pectus bar. So I have done 3 cases so far with the this technique, minimally invasive repair of Pectus arcuatum. Okay, thank you so much.
Thank you again, wonderful presentation. One of your aquarium, the way you bend the bar, there was some curves in the bar. Do you do that still now, or do you just keep it straight like the normal bending, the no-brainer technique?
Not as much as before, but still, I modified the bars today.
Yeah, I mean, what I saw just now in your video, the bar is a little bit concave. Do you need to do that for the aquatum, or can you just keep it?
Many times, yeah, I need to do that.
Okay,
But
you can't keep
what-
it like the no-brainer technique, just normal shape.
It's like the complete elevation of the chest wall with the crane, but this kind of things, we don't use any crane because the combination of the deformity. So
Okay.
it depends on the situation. When you need, we can do anything. So what we don't need to do anything. Okay, thank you.
The scheduled next presentation has been cancelled because of delayed surgery. So this concludes all of today's sessions. So
We have an interesting case.
안 하신다고 인공위성 얘기 안 하시고 5시에 출발하신다고.
했는데 난 준비하고 왔는데. Anybody has channel?
There are some interesting cases.
Okay, I'm gonna go.
현,
Anyway, he didn't finish the case. still in the surgery,
Yeah.
so we need some more time.
There are
We
some.
cannot leave Gongmin leave behind, so we have to wait anyway. I'd like to introduce a very troublesome patient. Actually, I saw this patient in Cleveland Clinic, but he got the surgery from some other institution, the 42-year-old male. He had 2 previous pectus bar surgery, and now his complaint was respiratory difficulty and labored breathing. So this must be the pre-op CT scan, and this is the after the first operation single bar approach. And as you see here, still remained residual deformity, and the repair was not enough. And interestingly, you see here we see the sternum here, but pectus bar is located under the sternum, below the sternum. So the bar doesn't support the sternum at all. In lateral view, it's more obvious here. It's not supporting. That's why the sternum is still depressed. So the bar must go up here or here, so to support the sternum. It missed the sternum. So he got a reoperation in another hospital. This time he got the 3 bars parallel. The repair looks pretty good. No much residual, and the upper part he has still asymmetric configuration, but this is just cosmetic, not functional at all. So we didn't do anything for that because he's already undergone 2 times. This is kind of minor thing, and the other part looks pretty good, well elevated. But as you see here, 3 bars here, and the 2 bars are missing the target here, below the sternum. As you see here, 1 bar support here, but the 2 bars below the sternum. That's why we don't do the parallel bars very low. In those cases, definitely we need the crossbars to cover lower than sternum. You need to do it this way. You cannot go into the abdomen. So the bar must be up above here. So this is the lowest point to the bars can go. That's the presentation. I only saw this patient in a clinic, so I have no further information for that. But what I like to indicate here is his symptom was it's a labored breathing. So once I saw him, his breathing was not easy, but I couldn't come up with any solution immediately at like a first meeting with him. But later I assumed that the reason for that is the lower, too much lower bar interferes with diaphragmatic movement. So his breathing was not easy. So the lesson we can learn from here is that we can't put the bar in very low that port. We can maybe get into the abdomen in these low positions. Any comments? I just told he wanted to do something like a asymmetric upper part may cause the respiratory problem or something like that. So it was unreasonable, and he was a kind of stereotyped. He didn't listen at all. So I couldn't do anything. Just keep saying that the make a osteotomy here and make it flat, something like that. So it doesn't do anything to your breathing capacity. So he didn't listen to that. So well, I couldn't proceed anything. And I recommended just three pectus bars in there, and then there must be interfere your chest wall movement when you're breathing in and breathe out. It's not easy for you with a very fixed chest wall. So you may need to remove the bar if you are very unhappy with that, or just wait one more year, and then when the time comes, you can remove the bar and then you can be free of the symptoms. But he didn't listen to me, so he's gone. No, not at all. Chest wall elevation is enough, and then it was just upper part was just asymmetric. So you can see here. This is the first surgery. Yeah, asymmetry right here, very upper part, above the aorta. So, and the lower parts are pretty well elevated, but it's too low. You see here the first bar support the sternum here, but the lower two bars not on the sternum. I'm sorry, I didn't check.
Yeah, one of my patients had a very tachycardia after the operation more than 6 months.
Mhm.
So he is very tired, and I think the reason was bar compression to the heart.
Yeah, it happens. But right here, I don't think the bars do anything to the heart here. And the final one. Maybe the Beijing children team had the same approach, I guess, but I actually this was not my patient. My colleague John DiFiore had this patient. Before I go join the Cleveland clinic, this patient was dealt with by the cardiac team and then the other doctors. So 2-year-old male and the aortic root dilatation and the Marfan syndrome and the very severe scoliosis and the Pectus excavatum here and the straight back syndrome. The kids' aortas keep dilating, so they plan to repair the aortic root, but they have to do the Pectus repair at the same time, but they have no experience with the very small children like this way. So I joined the treatment together here. Actually, the operation I did, the approach was when the cardiac surgical team fixed the aorta, and then when we closed the sternum, make a roof around the perichondral sutures, multiple sutures, and then the titanium plates were placed and tied to bring up the depressed chest wall. So this is the end result. The scheme shows this way. I made multiple pericostal sutures to bring up the chest wall up to the strut like this way. So final repair will looks like this way. There are struts here, and the patient was well, and then everything was good. So one thing was when we first done this case, the patient didn't thrive that evening. So the patient put in the ECMO and that they had to remove all this reconstruction and then reopen the sternum. And then several days later, we get in again, and then the ECMO was successfully removed, and then we did the reconstruction again. This is another one, 42-year. Yep.
For the 3-year-old child.
Mm.
In this instance, because it's metal plates
Mhm.
in a young child growing,
Mhm.
would you remove the plates at a later age?
Yeah, we may need remove. I thought we have two options. We can put the Pectus bar in. I had some experience with that. The cardiac surgery together with the Pectus repair. At that time, I put the bar in under the open sternum and then the closed sternum and the Pectus bar fixation there. But basically, Pectus bar is more burdensome for the patient. The more pain and the more rigidity. And anyway, we opened the chest so we can access externally to the rib cage. So probably, I thought the external strutting must be better option rather than the internal bar placement.
Yes, so I think it's great, but I'm just concerned because we know that the rib plates eventually will fracture with time. Because as the child grows, it can't be there permanently. We know that when we're bridging for chest wall,
Yeah.
after 5-7 years, the
Yeah, that's the point.
fragility cracks. So would you
Yeah.
take it out earlier? And then it also will restrict.
I don't think it's
growth,
permanent. I don't think it's permanent. But anyway, Pectus bar must be removed. Because patients, the child grows, Pectus bar is more restricting. Yeah. So we can choose Pectus bar or other options. I don't know, but I thought that this is the better way to do that. Yeah.
I agree.
Final one, but the 42-year-old male, he had the previous ravage operation, and also he complained about the respiratory difficulties and the chest pain. Right after the ravage procedure, he got some strut here. I don't know which one was there, but later he got removal of this plate, and maybe he had some recurrent. But always posterior ravage, looks like this way. We can't cure the chest wall deformity with a ravage. Actually, I call it post-ravage chest wall deformity. It creates another deformity. So this is the pre-op, pre-severe Pectus deformity. And then when he came to us, his chest wall looks like this way. Residual bone fragments here, and some depression here, and then irregular surface here. So in the operation, we found that the bone fragments protruding inside. This is the lung, and those are the tip of the protruding, like here. This looks like this way. So. And I removed this part of the protrusion, some couple segments, and then again the strut roofing with the external struts like this way. So it was very effective, and the patients were recovered very well. So I tried to report 2 cases of a strut roofing. Any questions, comments?
How did you anchor the struts?
Actually, I've been doing a lot of pericostal sutures from the beginning, like 25 years, because we did a lot of difficulties. When I first began this procedure, we didn't see inside, just blindly past the Pectus bars and the introducers, something like that. And then to fix the bars, first time we tried to lateral stabilizers, but it's a functionless, so I stopped using that. And then next one was a pericostal suture, multiple point fixations. at that moment, I did a lot of pericostal sutures. So I think I can do that. So yeah, we did that. Okay, thank you very much. Kongmin, can you show the X-rays for the last patient?